to introduce you to Dr. Donald Royall. Dr. Royall obtained his degree in medicine from the University of Texas Health Science Center in Houston, and then completed residency training in internal medicine and psychiatry at Johns Hopkins. He is board certified as a diplomat with the American Board of Internal Medicine and the American Board of Psychiatry and Neurology, and he also has a certificate of added qualifications in geriatric psychiatry. He currently serves as a professor in the departments of psychiatry, medicine, and clinical pharmacology at the Health Science Center here in San Antonio, and he's also head of the program in geriatric psychiatry. Most of you all are familiar with Dr. Royall, and you know that his research interests include the clinical phenomenology of dementia, clinical assessment strategies, and also the qualitative assessment of dementia phenomenology. And he was very gracious in agreeing to do this for us today. At the South Texas Geriatric Education Center at the Health Science Center, as part of our grant, we have put together a 27-hour symposium in health literacy and aging. And this is one of the modules of that symposium. So it is being videotaped and will eventually be available online. So please welcome Dr. Royall.
When they asked me to talk, they weren't very clear about what exactly the topic should be. They sort of said cognitive assessment, but you get the answer to the question you ask. So you can't really talk about cognitive assessment unless you define a particular problem. Sometimes cognitive measures are used to diagnose certain conditions or to detect dementia or to predict future decline or decision-making capacity or to whatever, screen for particular kinds of cognitive impairment. So you get the answer to the question you ask. So I decided to insert the question I think that is most clinically relevant, and that's no longer trying to detect dementia. It's pretty obvious. You don't really need many cognitive measures to predict dementia. I would say that one of the best things you could do as a busy clinician is just see if the patient comes with a caregiver. That turns out to be a very strong indicator of dementia, is that they're accompanied by a caregiver. Another sign of dementia, I start all my interviews with, "What can I do for you?" Right? And if they say anything other than, "Oh, I'm here to have my memory checked," or "I'm here to have my blood pressure checked," but if they say, "Well, you sent me this notice," that's dementia. Is that they should have a global picture of what's going on, where we're here, and I shouldn't be the one to have to give it to them. They should spontaneously offer these things up. So the idea of MCI is fashionable now because people are envisioning a time where you'll have disease-specific treatments for the major dementing illnesses, and why wait until they're demented to offer those treatments? Ideally, you would want to try to prevent dementia from developing, and what a lot of people don't realize is diseases like Alzheimer's start when you're my age, not when you're 80, and they evolve for 10, 20, 30 years before memory loss develops, and they're working on people the whole time. And so basically, if you had a treatment for Alzheimer's, you wouldn't wait until dementia. You probably wouldn't even want to wait until memory loss. You would come even earlier. So the trick is to find cognitive changes that are indicative of future progression to dementia. And because the pathology is so endemic, it's not really about detecting who has the pathology. You could just flip a coin and be right most of the time. Instead, it's going to be about who will change, whose cognition will evolve in time towards a demented outcome. And there. So when you're in a business long enough, you can see just about anything once upon a time. I've seen several ideas kind of explode on the scene and then pass away over time. And I kind of think that the MCI idea is an idea whose time has already passed, and we have to be thinking even more sophisticatedly about what happens in dementia, how these different diseases evolve, and what we can do about them. So I'm not a big fan of MCI, even though right now I think it has a lot of currency. And the key points are going to be that cognitive impairments often occur in non-demented people, so cognitive impairment alone isn't enough to indicate dementia. Some impairments are going to increase the risk of Alzheimer's, and they would be useful signs that if you wanted to prevent Alzheimer's, that you should intervene on this person, but others may not. So just because somebody has a cognitive impairment doesn't mean that they'll eventually develop Alzheimer's disease later. And how can you think these things through? Well, Alzheimer's is generally thought to be the most common cause of dementia, and the incidence goes up with age. Almost all Alzheimer's patients have memory loss, so memory is generally thought of as a good sign of Alzheimer's disease. But some of the cognitive impairments of Alzheimer's and even other signs predate the onset of dementia by decades. And so you might find cognitive impairments that predict future Alzheimer's, and yet they may occur so early in the disease that they're useless to you because unless you have a treatment that's going to work 30 years in the future, it's too early to be worrying about this. So the current situation is there's this concept called MCI, mild cognitive impairment, that was first developed by Ron Peterson, a neurologist at the Mayo Clinic. And to have this, you have to have some cognitive impairment that we can detect. Ideally, if you're going to predict future Alzheimer's, we would want to detect isolated memory loss, not global cognitive impairment, but isolated memory loss. No general cognitive decline in the other domains, because for those to evolve in Alzheimer's, you have to wait later in the disease. So if you have more than memory loss, you've waited too long to apply your intervention. No disability, because if you have disability, it's de facto evidence that you have dementia. The definition of dementia isn't cognitive impairment, it's cognitive impairment in a clear sensorium sufficient to cause disability. So if you don't have disability, if you have a disability, then the horse is out of the barn. It's too late, right? They're already demented. So you want to predict dementia at a point where there is no disability so that you could apply your treatment and forestall the onset of dementia. So basically, using those criteria, Peterson was able to show that a substantial fraction a year will convert to dementia in the near term, which is ideal for the use of a drug. You want to detect people not 30 years away from dementia, like some of the brain scans might eventually do, or biomarkers might do, but 5 years away from dementia. Because if you could find it 5 years away from dementia, then you could apply a drug that would slow or prevent the conversion. And all you have to do is delay Alzheimer's diagnosis by 5 years, and you would cut the prevalence of Alzheimer's disease in half just by delaying the onset of the syndrome. But he did that in memory centers, and nobody's been able to replicate that. So people have tried now in community samples, and it just doesn't work so well. So, for example, Ritchie et al., they found a very low conversion rate. So if you applied Peterson's criteria to a population, not just patients presenting with self-reported memory loss in a memory center, but to everybody and their grandmother walking through the doors of the VA, then you would find that very few convert. Many don't convert to Alzheimer's disease, which is what Peterson said he was trying to predict. And the diagnosis was unstable in the sense that 1 year they would be MCI, the next year they'd be normal, and then they'd be back in the MCI group again, and then they'd be demented, but then they'd be back to MCI again. So it didn't really hold together in time. And so there's a problem with it. And I think it really goes down to, you get the answer to the question you ask. There's more than one cognitive functions, and the DSM requires that to be demented, you have at least memory loss, some other cognitive impairment, and disability. So people are starting to realize that maybe there's many kinds of MCI. There isn't just amnestic MCI. Some people have cognitive impairment, but there's no memory loss. The most common form of that is dysexecutive MCI in dementia claim, is to not really have any memory loss but have a whole lot of executive impairment. It's particularly common in medical services We've published a couple of studies out of the VA here. Between 50 and 70% of medical inpatients have executive impairment, but past the mini-mental. So you can't call them dementia if they don't have memory loss, and yet they do have a cognitive impairment of some kind. But I wouldn't expect that pattern to progress to Alzheimer's disease, because Alzheimer's always causes memory loss. So if these guys have executive impairment and no memory loss, they're going to turn into something maybe, but that something isn't necessarily going to be Alzheimer's. And then there are other cognitive impairments that just don't involve the two most common, memory and executive function. But then you really are at sea. If you have somebody with isolated language impairment, he's probably at very little risk of developing dementia. He probably has, a stroke or something in language. He has a handicap, but not a cognitive impairment that's going to lead eventually to dementia, and a dementia that needs to be prevented. So why didn't it work? What's wrong with MCI? Well, the first thing to realize is that just about everybody has AD. If you look at the pathology. Some studies have been done in large communities, and if you went through San Antonio right now and autopsied every single person in San Antonio, then 50% of 50-year-olds would have Alzheimer's pathology. Already, 50. That's the average age of onset. But it's not anywhere except in the nose at that stage of Alzheimer's disease. This pathology starts in particular regions of interest. In the case of Alzheimer's, it starts in the nose. So their only symptom might be that they have some difficulty distinguishing smells. That would be their only symptom. They would not be demented. They wouldn't even have memory loss. You'll never find them with a memory screen, and yet they already have Alzheimer's, right? If you go to 70, 90% of 70-year-olds have Alzheimer's pathology in their brains, demented or not. So many people have Alzheimer's pathology that it's kind of ridiculous to think about finding the Alzheimer's cases. That's not the question you really want to ask. That everybody has Alzheimer's, really. The question is, you want to find the cases whose pathology has evolved to the point where they're developing clinically meaningful pathology symptoms. So, in other words, you're trying to predict dementia, not Alzheimer's disease. See? So basically, everybody has Alzheimer's. If we develop, which people are working on, a brain scan that finds all of this Alzheimer's pathology, it's going to say everybody in America has Alzheimer's and be useless as a screening test. Because most people are going to live the rest of their life and die and never develop dementia, right? So if everybody has the pathology, but few people have dementia, then it means that most people who have the pathology are not ever going to get dementia, and that's why the problem is complicated, because you can't assume that detecting signs of early disease means they're at risk for future progression. Because the truth is, maybe most people with Alzheimer's never get dementia, and just a tiny fraction do, and that tiny fraction is a huge number, right? 5 million cases in the United States and growing all the time, but still it's a tiny fraction of the number of people at risk. So it's kind of like an iceberg, and the tip of the iceberg is what we call Alzheimer's dementia, but there's a much huger pool of people at risk on the basis of having pathology. So if you screen for it with a brain scan, then everybody's at risk. If you screen for it with smell testing, everybody's at risk. Whole bunches of people are at risk. And maybe many of them, that's the first symptom, maybe many of them will die and never have dementia, never have memory loss, never go to the nursing home. But that doesn't mean they didn't have Alzheimer's, because at autopsy you would still find the lesions. And these are the lesions. So, what you're trying to say when you say who has preclinical AD is who has tangles and amyloid plaque in their brain, because those are the key pathological features of Alzheimer's. And here's the actual data. This is 2,600 people in Germany. This is from a guy named Brock and Brock, 2 pathologists in Germany. And they autopsied every single person who died in a village in Germany, regardless of age, right? And looked for Alzheimer's pathology. So this is the age-specific distribution of people who have no Alzheimer's pathology in their brain, right? And so very few people up in their 70s and above have escaped Alzheimer's completely, whether they're demented or not. We only think of 15% of people over the age of 60 as being demented. So most of these people are not demented, even though they do have Alzheimer's pathology. But go back to 40-year-olds. You know, it's striking that only 60% of 40 and 50-year-olds have no Alzheimer's pathology. So already, about half of 40 and 50-year-olds have Alzheimer's pathology, but it's in their nose. And these are the very earliest stages. At these stages, there are no clinical symptoms except maybe a little bit of trouble on a smell testing. And you can see already very large numbers of people have that phase of the disease, even 30-year-olds. 20% of 30-year-olds have this much Alzheimer's pathology trapped in olfactory regions in the very earliest part of the disease's evolution. And if you go to later stages here, where it's starting to get into the hippocampus and you might be forgetful, then you can see a clear shift towards old age. And so this is the beginning of what clinicians generally think of as cognitive impairment. In this case, you would detect memory loss because it's in memory centers here. And since it's not in the cortex yet, there would be no executive impairment, no language impairment, no other impairments. And so this would meet Ron Peterson's definition of MCI. And you're at about 20 or 30% of people over the age of 75. And if you go to the clinical stages, everything you think of as mild, moderate, severe dementia is just these last 2 stages out of 6 in the evolution of AD. So this is the tip of the iceberg, and here are the cases that we generally detect and call dementia, right? And that pathology fits the expected population distribution of Alzheimer's cases. So it's pretty close, about 20% of 90-year-olds, 95 or 20-30%. So basically, that's what we're seeing. It's just the tip of the iceberg. So Alzheimer's is progressing stepwise through the brain. And this is kind of a nice way to represent that. This is a study we did a few years ago from France. The data is from France. These are autopsies. Every single row here is a person who died on a geriatric inpatient service and was autopsied. And every single row like that is a part of the brain, a different region of interest. And we're looking at whether Alzheimer's pathology, the tangle, is present. And you can see that it spreads stepwise. No case has it here who doesn't also have it down here. No case has it here who didn't also have it here. This sequence starts out here with the hippocampus, the bottom row. But remember, there are stages off the chart here. I mean, if they had started with the olfactory cortex, they would have gotten more rows. And but they didn't. They picked up the story with memory loss. So the hippocampus, and then the parahippocampus, the interrhinal cortex. So it's spreading along synaptic connections. This is how Alzheimer's works. It starts in your nose and spreads backwards to all the regions of the brain that are wired into the nose. And then it spreads from those to the next neuron, and from that one to the next one. So it's like dominoes, going back into the brain. But what I liked about this data set is it showed you who's demented. The red here are the demented cases. So you can see that even though all these people have Alzheimer's pathology spreading through the brain, you don't really start to develop dementia until it reaches the 7th step here in this sequence, right? The 7th step. And that included 4 regions of interest. It's kind of interesting. Every other step, the disease spread to one other place in the brain. But once it gets to this one, it spreads simultaneously to 4 places, and you turn into dementia all at the same time. So what occurred to me is that by analyzing this data, I could find where in the brain does dementia start. And then you would know what you had to screen for to find dementia. And so we did this kind of analysis called a cluster analysis. And the pathology is clustered in 2 clusters. These early places here are in the limbic system. The hippocampus is in the limbic system, the interrhinal cortex, the parahippocampus. But dementia doesn't cluster with this group. You got to go over this hump here and get down into these, and then dementia occurs. And that's the cortex. So basically, as long as the pathology is trapped in the limbic system, the emotional systems, which are linked to your smell, that's why smells invoke emotional memories all the time, right? Because smell is part of the limbic system. Then, as long as the pathology is trapped in there and doesn't get out, then there's no dementia. But once it gets over this hump here and starts to invade these other parts of the brain, which are the cortex, the outside of the brain, then clinicians detect you as a case and label you as dementia. So the question you're really asking when you try to screen for MCI that's going to convert to AD is, what can I screen back here that will predict the pathology going over the hump and landing in the cortex? See, that's the question you're really asking, not who has Alzheimer's, because they all have Alzheimer's. It's just a question of where in the brain it is. So everybody has Alzheimer's, but it doesn't always progress, because most people who have it live the rest of their life and die, and they never get dementia. So why do we think MCI is going to progress? In other words, if most of the people in the world have pathology way back here, and few have it way back here. I mean, think of the odds. This is like 9 out of 10 people over the age of 70 have Alzheimer's lesions in this part of the slide, but only 15% have pathology in that part of the slide. So maybe that would be, 4 to 6 times more people have pathology trapped in this early phase of disease, and they haven't gotten over the hump. So if few people ever get it, then why, if we detect the pathology when it's back here, would we expect it to progress over the hump? See, and that's why it doesn't work to screen for dementia with a memory test in the real world, because they're not over the hump. If you screen for dementia with a memory test in a memory clinic, chances are it's already over the hump. It's going over the hump. That's why the patient self-selected himself to come to your clinic. You see? And that's why MCI screening worked for Ron Peterson in the Ivory Tower of the Mayo Clinic. But it doesn't work generally for the real world, because in the real world, most of the population is back in this stage of the disease, and it's never going to get over the hump. So it's very hard to use memory tests to predict who's going over the hump. Another way to think about this is in change, right? Change in time, because you're trying to predict who's going to actually be changing, as opposed to who has some cognitive impairment but they're not changing in time. So you're trying to predict the movement. And one way to look at it is this is drug study data from one of the earliest Alzheimer's drug studies. So presumably everybody in here has Alzheimer's disease. They all have clinical Alzheimer's disease diagnosed by the investigators and put on the wonder drug, which in this case happened to have been Aricept. And we have 2 doses of Aricept, and then we have placebo. And this graph shows you the fraction of people who achieve different levels of response on the outcome measure. And anything going this way is improvement. Anything going that way is deterioration. Okay? So you can go up here and find the line and find out that 80% of the people who took the wonder drug stayed the same. They had no change, or they got better. And of course, that's what you hear from the drug salesman. If you put them on Aricept, 80% will stay the same or get better, right? And you're supposed to say, wow, since Alzheimer's gets worse, then staying the same is good, right? But the placebo group, the answer was 60% stayed the same or got better, right? 60% of clinically diagnosed AD cases in this study who got placebo stayed the same over time or got better. They didn't get worse the way your brain makes you expect them to get worse. So basically, they can sell the drug by suggesting, by playing to your prejudice. Your prejudice is dementia is a terminal disease that always gets worse. But 60% actually didn't. So either cognitive impairment doesn't necessarily lead to change, or the diagnosis was wrong, right? And there probably is a little bit of room for both being the problem in a study like this. But I think you can't assume that Alzheimer's disease, the clinically diagnosed Alzheimer's disease patients evolve in time. And so you can't assume, therefore, that MCI evolves in time. And so finding MCI doesn't predict who evolves in time towards dementia. So it's not working out here. Instead, it's not actually the memory loss that predicts dementia, it's change in memory that predicts dementia. Because if your memory, if you're in the group that is changing in time, chances are you've picked up the ball, you're running with it, and you're going to end up crossing the goal line and becoming demented in the next few years. So it's not the memory loss that impresses me, it's change in memory loss that impresses me. Because that puts you in the group that's going to progress, and it's not a very big group, but it helps to know there's change. So we did a study of this out of the Air Force Villages. This is a memory test. So we tried to predict future dementia from baseline memory, age, your dementia type at baseline, and change in memory. And it turned out that of all of these, the only one that didn't predict future Alzheimer's conversion was memory. So independently of baseline memory, change in memory was better at predicting who became an Alzheimer's patient. See? So basically, it's better to pay more attention to the change in cognition than it is to the raw test performance. That's been shown in other ways in the literature. Here is drug response to one of the drugs, ribostigmine, another Alzheimer's drug. This is improvement on the outcome measure. Generally, one of these drugs will give you about a point or two improvement, generally less than a point, and that's what they got here in the group of people who their scores were not changing over time before they gave the drug, right? But there's another group of people. These are people whose scores had been changing in the months up to when they got the drug. And we know that because they were actually people who had been in the placebo group, right? And then after being in placebo for 6 months or so, they actually put them on the wonder drug, and then they looked at their response. And if over the placebo exposure their cognition had gotten worse, then there was 3 or 4 times bigger improvement in cognition from the drug. In other words, the real AD patients who are moving towards dementia can improve with the drug, but to find them, you have to not look at the baseline memory, but look at the change in memory over time. So what this might mean is if you're going to put someone on a wonder drug, then what you would do is when you first think about it, just not do anything, wait 6 months, see if there's actually change in the guy's mini-mental score, and if there's change, then he's designated himself as somebody who really is turning into dementia and who may have a better treatment response. So the change is a more important indicator than the raw memory score. Okay, another thing that's wrong with MCI is that memory, what makes you demented is disability. What makes you disabled is not memory. It turns out to be executive function. So what you really want to know when you're saying who is going to become demented in the near term is who will develop executive impairment in the near term, right? Because memory doesn't predict disability anywhere near as good as executive function. And we've shown that in a study. This is change in an executive test called the exit as a predictor of change in functional status. And the exit is pretty strongly correlated with change in functional status, independently of all this other stuff, age, level of care, disease, baseline exit, and baseline IDL. So change in executive function is a potent predictor of change in functional status. Functional status is what defines dementia. So executive function is the most important cognitive domain that you could be screening with to find the people who are going to become disabled by their cognitive impairments and then satisfy criteria for dementia. This is a more complicated model, but basically now we're going to have the exit predict change in functional status, but here's memory. change in memory is not significantly related to disability independently of executive function. So these people probably had Alzheimer's and they're developing a memory loss, but that memory loss is not why they become demented. It's the executive impairment instead that determines that. Okay, and then I think if you go all the way with that, what that means is that some MCI cases are already demented, they just don't have Alzheimer's, right? And so they're never going to turn into Alzheimer's because they don't have Alzheimer's. They have something else. And they're never going to turn into dementia because they already have dementia. And the way to think about that is the definition of dementia right now is very biased by Alzheimer's. And you can't be called demented unless you have memory loss. And Alzheimer's gives you memory loss because of the way it marches through the brain, starting in the nose and going back. So it inevitably goes through the memory centers on its way to the frontal lobes where you develop executive impairment, become disabled, and turn into dementia. So the only way to the frontal lobe is through the hippocampus for Alzheimer's. And so all demented Alzheimer's patients are going to develop memory loss earlier. But if you're outside of Alzheimer's, none of that's true anymore. Because if you have strokes or depression or many other conditions, there's no reason why they would necessarily start in your nose and go backwards, or why they would go to the hippocampus at all. There's many ways you can get executive impairment, but it's the executive impairment that disables Alzheimer's patients. So if these other diseases cause the same executive impairment, the same disability, right, but no memory loss, then right now the criteria would not recognize those as demented, and it would force you to call them dysexecutive mild cognitive impairment. But they're not mild. They're just as disabled as the AD cases, because they're just as executively impaired as the AD cases. They just don't have memory loss because they don't have the same disease, you see? And so the nomenclature forces you to call them MCI, but they're already demented. And so that's a fundamental challenge for MCI. MCI can't handle that. It tries to, the name itself suggests that this is a mild something that will turn into a something else. But they've already arrived. They're at their dementia for whatever their disease is. And it's not going to go anywhere from there because they're already at the end, right? It's just a different dementia. So we tried to guesstimate that in the Air Force Village again. This is the fraction of people who have memory loss, so some are unimpaired, some are impaired, and executive impairment on a clock neuron test. Some are impaired, some are not impaired. So if you pass both tests, you're normal. Most people were normal. If you have memory loss but no executive impairment, you're not disabled, so that would be MCI. Here they are. If you fail both tests, then you're going to be demented because the executive impairment will give you disability, and the memory loss means that that dementia is probably Alzheimer's. And you can see there's more MCI cases than there are dementia cases, but there's this other group, and it's as big or bigger than MCI. And these are people who have no memory loss, but they have executive impairment, and they're disabled by it. They're as bad as the dementia group, because the memory loss doesn't predict disability. It's just the clock drawing that predicts the disability. So this is a disabled group of people who have a cognitive impairment, but no memory loss, and they're going to be called MCI, but they're never going to go to dementia because you can't get Alzheimer's starts in the nose and goes back, so the memory loss is first, you see, and so you go from normal to MCI to dementia. That's how Alzheimer's would work. But these are people who presumably went from normal to type 2 dementia here, and that's it. They're already there. They're already demented. It's just not the same kind of dementia as Alzheimer's. So MCI doesn't handle that very well. Anyway, if we go back to these people, I think I can show you this executive impairment again. Oops. I don't know what that is. Oh, well, this just shows you that here's the average age that the people fail a common memory / global cognition test, the mini-mental, versus executive function on the exit. So you can see that many more people are developing executive impairment as they get older than memory impairment on the mini-mental. So the exit finds the impairment way early when very few people have failed in mental. That's backwards from what Alzheimer's would do. And so all it's really saying is that most old people don't get Alzheimer's dementia as they get older. They get something else. And this something else is sort of anti-Alzheimer's. You get the executive impairment, but no memory loss. Okay. This is just to show you how bad the executive impairment is. Here are exit scores. High scores are bad. Here, anything over 15 is impaired. And these are 3 groups here. These are all normals. Here are children between the ages of 6 and 11, young adults, and well elderly people in the Air Force villages with normal mental scores. And so their executive impairment is much worse than normals, young adults, and comparable to children. Which is why people have to look after them. People have to watch their bank accounts. People have to give them forms at a 3rd grade level, even though they have college educations. People have to talk to them real slow and explain to them that here's how you interact with the VA's pharmacy refill computer, right? Because it's like talking to a 6-year-old, right? Literally. Would you let a 6-year-old self-administer insulin? Would you let a 6-year-old self-administer broncho inhalers? Would you teach a 6-year-old how to manage their diabetic diet? Right? You just wouldn't do that. You'd go get the mom. But until you realize that this is what executive impairment is doing to well elderly people, then you can't realize how much of a misnomer it is to label isolated executive impairment as mild anything. It's just a different dementia. But it's a dementia that can't be diagnosed in the absence of memory loss as DSM card-carrying dementia, so it gets mislabeled as MCI. And it doesn't predict anything because it's already there. It's just going a different place, and the criteria can't accommodate it. So cognitive impairment is common in old age. Some of that may be due to preclinical AD, but most preclinical AD, in terms of the pathology, will never progress to dementia. So starting with the memory loss and trying to predict dementia to Alzheimer's conversion doesn't work very well. Change in memory is a more sensitive indicator, I would say, because then you know the ball is rolling and this individual is going to progress from his preclinical AD to full-fledged AD. So change in memory is more important than memory function per se. But executive impairment is disabling and is equally important to detect, but it's not going to turn into AD. It's going to be its own animal. It's going to be whatever it is. So executive impairment is going to be needed to convert memory loss into dementia. Because memory loss won't disable you, you're going to have extra executive impairment. And that means that if you only have memory loss, no executive impairment, you're nowhere near the conversion, so you don't have a problem. And if you have the opposite, if you have executive impairment but no memory loss, then you've already lost the game. You're already demented, but the diagnosis isn't going to be AD. Okay, so what this is really saying is that part of what's wrong with MCI is that it's a static something. You're screening for cognitive impairment, but it ought to be a dynamic something. What we ought to be doing is building screening strategies that are sensitive to changes. And not so much do you have memory loss, but is the memory loss you have evolving in time, right? So is your cognitive function changing? Because that would be a better way to think about it. And I have an approach to that we would play around with. So, we've been out at the Air Force Village testing ostensibly well elderly people longitudinally. So we've looked at 600. Everybody was in their 70s when we started the study. They were in independent living, and we looked at change in cognition over time on 22 measures. Here they all are, this whole battery of tests. And basically, everything here is graphed in a way that if they go up, they're getting better, and if they go down, they're getting worse. So the first thing to notice is that not all cognitive functions get worse as you age, right? A bunch of them actually got better, and some stayed the same, and others got worse. So cognition really is going all over the place as people get older. It's not all inevitably downhill. Some things get better, some stay the same, some get worse. But to be demented, the cognitive declines that we can show aren't enough. You've got to also have disability. And on top of that, the two have got to be related. So maybe some cognition gets worse, but like memory, if it doesn't predict functional status, who cares? But if it does predict functional status, then you have a problem that will lead inevitably to dementia. So what this tells you is that cognitive impairments that don't explain variance in functional status are not really part of the dementia syndrome. And we shouldn't be confused by them. We're sort of confusing ourselves. Alzheimer's always causes memory loss, but memory isn't why Alzheimer's patients are demented. Alzheimer's patients are demented because they're disabled, and they're disabled by executive impairment. So it's still the executive impairment of Alzheimer's patients that explains their dementia. And by screening for memory, we're checking the wrong thing. And it also means that by screening for memory, we undervalue these non-Alzheimer's patients who have just as bad executive function and nothing else. Because they don't have any memory loss, we think of them as mild. They're not mild at all. They're just as disabled as the Alzheimer's patients. So, so basically, the question we're really asking with MCI is who is having a cognitive change in time that predicts change in functional status in time, and how do we find those guys? So I think we can think of this as like a vector. So we have functional status is getting worse in the Air Force villages over time. On average, it got worse by almost half a standard deviation over 3 years. And cognition is getting worse in the Air Force village on some measures, not all of them. But this data comes from the exit, an executive measure. And so these two angles here make a vector, and that's the dementia right there. It's revealing the dementia, because every change in cognition going down makes a change in functional status going across. And so I can measure this vector here, and it will tell me which people are dementing, which cognitive measures are most sensitive to that dementia, and which interventions I would want, which measures I would want to intervene on, because if I make this vector go back the other way, I'm going to make functional status go back the other way. But if I make some other cognition get better, it may make no impact on functional status, and I'm just sort of wasting my time. So we can think of it as a space now. Zero would be no change, and if we followed them in time, we could take any measure we want, memory, language, whatever we want to try, and look at what happens over time. And if functional status gets worse, they're going to go that way. And if cognition gets worse, they're going to go that way. So any vector in this quadrant is defining a dementing process, and it's something we should pay attention to and try to fix. On the other hand, if the vector went that way, it would mean that while functional status got worse, cognition got better. That's not dementia. That would be, stubbing your toe. If you stub your toe, functional status might get worse because you can't run anymore, but your cognition is not changed, so you'd be up like this. If you map to this zone over here, that'd be uncoupled cognitive decline. Basically, cognition would be getting worse, but functional status would be getting better. So you've been given your motorized scooter, right? And so even though your cognition got worse, you can actually get around better now. That's not dementia. So if you were in this zone, that'd be cool, because that would mean that your dementia is being fixed. So if last year you were that way and I gave you the wonder drug and your vector flipped, then I would be detecting that your drug is making you actually better. But if instead the drug made you go like that, then it would be useless, because functional status wouldn't be improving. I would just be making memory better, say, or cognition, but not really achieving anything. So this is kind of a handy way to look at it. And so we did this in the Air Force Village data, and here's what we found. Basically, here are the 22 measures. On average, everybody the functional status got worse on average. But now we can tell exactly which tests detect the dementing process going on in that population. And it turns out that they're drawing tests and executive tests. Everything related to memory or language is up here. So this is California Verbal Learning Test. It got better at the time. Vocabulary got better. Verbal fluency got better. Boston Naming Test got barely better. But nonetheless, functional status got worse. So none of those measures are related to dementia. But on the other hand, clock drawing got worse. The mini-mental got worse. Block design, digit symbol, trail making, the exit, another trails test, and clock drawing. So what that says is whatever's eating the people in the Air Force Village, it is a dementia. It's disabling them. But it has nothing to do with memory, so it can't be Alzheimer's. If it had been Alzheimer's doing it, then they would have declined in their memory function over time, and we would have picked it up as a vector going this way. So instead, something is eating the Air Force villages, and it's mostly limited to tests that we would think of as being in the right hemisphere and the front part of the brain. Now, I'm not saying I know what it is, but I'm saying that it doesn't look anything like Alzheimer's, and we can generate hypotheses about what it is and try to fix it. Actually, this data is a couple of years old now, and we're already into it. It turns out that the sides of the brain inhibit each other. And so if you knock out something on the right side of the brain, the left side is released from inhibition that it used to be inhibited by the other side, right? So I think what's happening here is there is a disease process selectively destroying the right hemisphere, and the left hemisphere's verbal functions are allowed to improve. And that's what explains this pattern that we detected here. And I used to think this was normal aging. There actually is a literature on what's called the right hemisphere theory of aging, because it was noticed 10, 20, 30 years ago that age is a better predictor of drawing tests than verbal tests, right? But now I'm not so sure it's aging itself. It might be oxidative stress or something wrong with the, we think that there's more atrophy on the right side of the brain, and we now know that the atrophy on the right side of the brain in aging is related to the white matter, not so much the gray matter. And so it may be that oxidative stress is selectively killing neurons on the right side of the brain, or a virus or something that's getting into the white matter. And as the right side succumbs, then the left side is released from inhibition. And one of the interesting things about the right side of the brain is the connections are actually longer on the right than the left. So the neurons on the right have higher metabolic demands. So if you had something that was subliminally messing up the metabolic functions of the neurons, it would take out the right hemisphere before the left, because the metabolic demands in the right hemisphere are higher than the left. But anyway, whatever it is, it doesn't have anything to do with Alzheimer's or tangles or pathology spreading from your nose backward into the brain. That just can't explain what's going on with these normal aging. Nonetheless, we can see that it's a dementing process because it's in this quadrant of the graph. So we have detected a preclinical, to be named later, dementing process, which, I mean, we don't even know the name of it. But it's very common. It's hitting the average healthy, quote-unquote, elderly person out there. And now we could go after it and try to find out the biomarkers related to it and understand what it is, and then we would be able to intervene against it and fix it. But the only way we detected it is by graphing the change in cognition against the change in functional status. So that's basically what I told you. So basically, change, looking at change, gives you a way to define which cognitive changes are clinically meaningful because they're related to changes in functional status. And then you don't need a book to tell you what dementia is. You can just let the data tell you. And when you graph it that way, you can find new dementias you didn't even know existed. And so essentially what what we're doing is establishing the foundation for a new conceptualization of dementia based on changes in time. And when you apply that to what appear to be the well elderly, you realize that they're not well in the sense that something is eating their cognition, maybe selectively eating the right hemisphere's brain functions. And once we figure out what the pathophysiology is, then maybe we will be able to do something about it. So, in conclusion, the whole idea of MCI is just overly simplistic. It's a little bit naive, and it's not very useful. Cognition, as people get older, evolves all over the place. Some cognitions appear to get better, others stay the same, others get worse. So there's no one thing that's going to predict cognitive decline. Only some of those vectors are related to disability and therefore dementia. So you're going to have to go beyond just seeing that cognition is changing to identifying the specific cognitive measures that are finding the changes that lead to disabling outcomes, because those are the ones that are describing your population's dementia risk. And for the well elderly, at least, who are not obviously, they're not pre-selected as being memory impaired or anything like that, then it was executive and nonverbal measures that were demonstrably relating to dementia as a process, and the memory and verbal functions were not so important. But if you studied 1,000 Alzheimer's patients, you might get a picture that was really different, and it would emphasize memory more in its characteristics. And if you went to a diabetes clinic, you'd get a third picture. But in each case, this technique would find the cognitive functions for that population that define its dementing process and offer you the best chances of screening for it in the future and reversing it, or watching that you're reversing it in the near term. So, I know that was a complicated talk.
Can I ask you a question?
Sure.
My mother had Alzheimer's, and she developed it around 1970. The only reason why we found out was because she would wander to the neighborhood. She would walk, because she loved walking. She would walk over 50 miles, she knew all the neighbors. And when she had to return back home, she couldn't remember, but she knew all of our phone numbers, because she'll be calling, she'll go to a neighbor's house and call, and, come here to the hospital, call one of my sons to pick her up. She had diabetes, she developed cataract, and she lost vision because she had bleeds behind her eye. And then down the road, she lost some of her vision. But when we took her, we took her to a neurologist, but they couldn't figure out what was going on. So do you mean when you say that it starts, could she have had the Alzheimer's prior to, before she was 70 years old?
Yeah, so what I'm saying is just about everybody has Alzheimer's by the age of 70 for sure.
She was at that age.
But most of them will never develop dementia from it. Okay, so, and then think about it. What do you need to be demented if all you have is memory loss? You gotta have disability, because memory loss alone doesn't explain disability, so you wouldn't be demented. And to get the disability, you have to have executive impairment. So if many, many people have Alzheimer's, and a big fraction of those have memory loss, but that's all, right? And no risk of future dementia. Then all it would take to fool us into thinking that they had Alzheimer's is new executive impairment. And many things cause executive impairment that are not due to Alzheimer's, like little strokes. Diabetics are at risk for strokes. Or depression. Diabetics are at risk for depression. Or hypoglycemia from taking insulin. Diabetics take a lot of insulin and they have hypoglycemic cells. Any one of those three things could cause executive impairment and then disability. And then you would have the full syndrome. You would have memory loss, executive impairment, disability. The doctor is going to look at you and say, oh, well, it's Alzheimer's. But the truth is, you got to follow the executive impairment. It's the executive impairment that explains the dementia. Her Alzheimer's pathology isn't anywhere near the frontal lobe yet. It's the diabetes risks that are causing the dementia. And so if you put her on a cholinesterase inhibitor to prevent Alzheimer's, you're missing the point. The point is she needs better diabetes control and better stroke risk management, and maybe antidepressants. Because any one of those three things could have flipped her into dementia. And another thing you'd notice is that 10 years later, she wouldn't be any worse because the Alzheimer's pathology hasn't started to roll, to move, and or not necessarily. So one of these mixed cases, they have less risk of progression. So what it means is that half of the clinically diagnosed AD cases in that drug study didn't get worse on placebo because maybe they were these mixed cases instead. Anyway, some of them really do have Alzheimer's dementia, but a lot of them don't. And the fraction, how many are real AD versus these mixed cases, depends on the setting that you practice in. And the VA is a setting where the mixed cases dominate. So ironically, the VA is a place where there's relatively little Alzheimer's disease and much more vascular disease and these other dysexecutive syndromes. So executive impairment is a much bigger problem in the VA than memory loss. And yet, if they don't have memory loss, we fail to detect them usually. The doctors don't refer them to the memory clinic because they don't have memory loss. Right? But all we have to do is go to the diabetes clinic, and 57% of them have executive impairment.
She graduated from medicine.
Yeah.
She could swallow.
Right. So she could have had the real AD. But what I'm saying is that the story alone, you can't tell because the picture is identical whether it's a combination of disease processes or whether it's just one. So only in time can you tell that she probably had real Alzheimer's because she got worse in time, whereas the mixed case would.
On the recent research that I've done, can it be passed down to the children?
No, it doesn't tend to do that.
No.
Yeah. It clusters in families, but that's about as far as you can go with it. It's not really that much of a genetic disease. We don't have a genetic blood test for it, for example, because none of the genes we know about are good enough at predicting Alzheimer's to work as a blood test.